The case we are presenting today is a young girl, 28 years of age. She suffered an injury to the left knee with a twisting mechanism and suffered an injury to the ACL. If we see the sagittal images, you can see that the ACL is torn here. Can you see the image here? And there is a hyperintensity on the femoral side. So this is called as a type 1 Sherman injury to the ACL. That means the ACL is avulsed from the femoral aspect. And in these kind of special scenarios, we will consider strongly about doing a primary ACL repair. And in the live surgery, we will be demonstrating about how best we can do primary ACL repair surgery. We will see intraop. Occasionally in these patients, augmentation with a graft or an artificial ligament may be required. But if the intraoperative ligament is good and it is avulsed from the femoral side, we will be trying to do a bundle specific reconstruction of the ACL. So you can see it in all the images. Specifically, there is some hyperintensity in the ramp area. We are not very sure about that. Rest of the findings are normal. And if we see here on the coronal images, the same thing is visualized here as well. So you can see hyperintensity at the insertion of the ACL here as well. So in the coronal images also we can appreciate that there is a tear on the femoral side. And if we see about the axial images, the same thing you can appreciate in the axial images as well. And you can see that there is a avulsion kind of an injury onto the posterior part of the femoral condyle. So basically this is a type 1 Sherman injury in which there is very little stump on the femur and whole of the ACL is avulsed from the femoral side, and these kinds of injuries can now be repaired and with a very good result, because we can reassure more proprioception and more natural healing to these patients as compared to an ACL reconstruction surgery. So let's start the live surgery. Good morning everybody. We have started the diagnostic examination, and so it's a very good technique to repair the ACL primarily with this technique. So just do a gentle tap with the hammer, please. Okay, go ahead. Very good. Go ahead. So I would usually recommend doing a double row kind of a repair. Go ahead. Because I would like to do it a bundle specific kind of a repair. So we all know that the ACL has two bundles, the anteromedial bundle and the posterolateral bundle, and I would try to reinforce both of them by use of two all suture anchors. Now this anchor is very specific. It's an all suture anchor. It's 1.7 mm drill. The suture size is very small. It is a 0 number suture which is there, which is a very small or a low profile sort of a suture. We'll do a gentle seesaw maneuver of the suture to just lock them into their place. And now I would be inserting my second anchor. This is basically for the PL bundle or the posterolateral bundle. So you can see that this is for the PL bundle or the posterolateral bundle. Very good. And both of these will also give rise to a lot of bone marrow elements which are coming, which are helpful for the healing per se. So in this case, we want a primary healing. That is why we have done a small microfracture at the portion of the footprint per se, and then we have done two anchors specifically in the area of the resident ridge, because the attachment of the ACL will be posterior to the ridge. Now what we can see is actually the ACL is actually folded outside, and we need to take back this into its place. Now this is the right time where I would love to just increase the extension of my a little bit, shift my weaving portal onto the medial side, and there we will see 4 anchors, 4 suture limbs, small suture limbs which are coming from the superior anchor, and 4 suture limbs which are coming on from my inferior anchor. My ACL is there, it is like a folded ACL. Pro please, and cannula please, cannula please. And now I would, knife please. Now I would make my lateral portal a little bigger, so I'll just increase the dimensions of my lateral portal like this. And then I would be using a 7 mm debut cannula to actually pass my sutures or hold my sutures. Can you hold, come here and hold this like here, okay? So what you can appreciate is now we have shifted it up. Now we have shifted it up and we are holding the scope in the medial portal. The upper anchor you can see very well, the lower anchor you can see very well, and there is a cannula which is coming from the lateral side. Green retriever please. And at this point of time, just remove the lower artery please, lower artery remove please. We will be starting our repair from inferior to superior, okay? And this one, this kind of a repair will be done. This is a fine repair. This is a repair which is something like our rotator cuff repair, and we will be using a knee scorpion for this kind of a repair. The knee scorpion is pretty handy to use with this kind of repair because knee scorpion is a low profile instrument and it will take only 20 or number 0 sutures into its flange. So that is why the knee scorpion is a very, very good device to do these kinds of repair. Green retriever please. Green retriever please. So you can see that we have passed the first suture into its place. So this is the first suture from the inferior. Okay, so we are good here. Give me the grasper. Give me the grasper. So I'm good. So this is my first suture, and this first suture will actually bring my ACL into a more normal position. If you can appreciate, the ACL which was folded back now is in a more normal position. We are able to see the ACL more normally. You can see the substance of the ACL more normally as compared to before. Now this is the second suture. This is the blue suture. Here we will be taking only simple sutures. Please hold the cannula. Here we will be holding only the taking only the simple sutures into its place, and we will be taking the second bite like this very nicely. The important thing you must realize is, because this is a sort of a crowded area, you might have problems with entanglement of the sutures, and you should be good in suture management. Don't. You should be good in suture management, and you should be able to clear out all the problems in the suture management. So that my 2 anchors are in position. I have passed 2 sutures from each and every, 1 suture limb from each and every suture anchor onto its place, and then now I will be starting to tie my suture limbs. So you can see that these are the 2 suture limbs which are from the inferior anchor, these are the 2 suture limbs from the superior anchor, this is the 2 suture limbs from the superior anchor, these are the 2 suture limbs from the inferior anchor. So there are total 8 suture limbs, 1, 2, 3, 4, 5, 6, 7 and 8, and at this point of the time I would be starting to repair my At this point of time, I would be starting to repair my ACL in this fashion. Okay, just leave it. Okay, so this is my first suture limb. Hold my camera like this. Okay, so here you should see, understand the arrangement. My knee is about 30 degrees of flexion. I would want my knot to be on my ACL stump, so I'll just pull the other wire around. and then I would just take a simple knot which will come like this, and this will close my ACL very nicely into its place. So the first knot will actually close the ACL, and the flipped part of the ACL is now repaired, and we can see a very nice tensioned ACL back into its position right there. So this is the first suture, and this will give us the desired reduction of the flipped part of the femoral avulsion, and then we are free to extend our or do the other parts of our repair properly. So this is my first suture limb which is cut. Now I would be tying my second suture limb again. This is again for the AM bundle, the superior part or the superior anchor. It goes like this. I try the other one. I pick it up. Again make the knot on the ACL, so the tissue which is passing through the tissue. So these are all the things that we have learned from our experience of the rotator cuff, and we'll doing the same kind of a repair. So earlier I used to do the knotless pattern of repair by using a lateral row anchor, but I have given up that technique in favor of this technique because this is a more minimal invasive technique. The sutures that we are using here are very low profile. It's a modular technique. You can modify your tension. You can place your sutures more accurately. There are less chances of any cutout. The repair is very good, and nowadays it is recommended that in ACL primary repairs, the recommendation of suture bracing or internal bracing is also not that much. You can achieve good results without internal bracing also. So the natural healing is the paramount, and what we are trying to achieve here is the best possible natural healing that we can achieve by use of all the natural methods without using a lot of artificial material. That not only reduces the chances of inflammation but also reduces the chance of actual infection, because we don't want unwanted material there, because the body heals. If the body is healing naturally, we don't want any extra thing to aid to it. So that's why in this particular technique we are not recommending the use of the internal brace technique. If you are doing this technique, this technique alone is sufficient. You don't need to do internal brace associated with that, and that makes the surgery very safe surgery. It's a physeal sparing surgery. So if you are doing it in a young patient, it is a physeal sparing technique. You don't drill anything into the physis. You are very safe as far as your the repairs are concerned. There is minimal foreign body, so that you can actually it's more like whenever if the healing takes place, that it will be more or less like a normal ACL or a normal sort of feeling for the patient, because whatever we have done is actually led to the repair of the torn ACL, and there is no foreign material which is involved in the repair or reinforcement of this tissue. So you can see that now the ACL, the repaired ACL is coming into picture. It is looking very nice. It is looking way too accurate for our repair. All the 4 sutures that we have used have actually done their purpose perfect, and the looks of the ACL, if you can appreciate as compared to where we started from the surgery, have improved, and now it's a very nicely looking ACL, very beautiful looking ACL without any of the foreign body material which is significant, without any tapes, and we hope that this patient recovers very nicely or very well with the use of this natural preserving techniques or repair techniques. So this is our technique for primary ACL of the primary repair of the ACL using the OsteoCare OsteoKnot anchor, which is a very low profile anchor with very minimal